Hello, everyone, wherever you're joining us from today. Thank you for being here and for continuing to be part of this global community. Each month, we come together because knowledge matters. For families navigating neuroblastoma, understanding research and clinical trials is not abstract. It shapes real decisions, real timelines, and real hope. I'm happy to share that our educational webinar series has grown significantly, reaching and supporting thousands of families across over 50 countries. Thank you for trusting us and for continuing to join these sessions. Clinical trials play a central role in neuroblastoma care. They are how standards of treatment evolve, how new therapies are tested, and how progress becomes possible. At the same time, they can feel complex, overwhelming, especially for families trying to understand what options exist and how they fit into their own child's journey. Today, we are honored to welcome Dr. Rochelle Bagatell, Chair of the Children's Oncology Group, COG Neuroblastoma Committee. Dr. Bagatell is nationally and internationally recognized leader in pediatric oncology and in neuroblastoma research. In her role at COG, she helps guide the development and direction of clinical trials that shapes care for children with neuroblastoma across North America and beyond. Today's session will focus on the COG clinical trials update, where we are today, which studies are currently open or in development, and how ongoing research continues to move the field forward. For families, this information is a powerful tool to better understand options, ask informed questions, and feel less alone when navigating complex decisions. Dr. Bagatell, thank you so much for being with us tonight. We are truly grateful for your time, your leadership, and your commitment for children and families affected by neuroblastoma.
My pleasure to be here. Thank you so much for organizing this, and thank you to everyone who's joining us. I'll give a background about COG and about COG trials, and then I think there should be time for questions afterwards. So I will share my slides. Is that okay? Can you see the slides? Yeah, okay. All right, great. Here we go. All right, I think many of you know quite a bit about the Children's Oncology Group, and maybe some of you are even joining from North America, as well as Australia, New Zealand, and maybe Saudi Arabia. But many of you are not part of the Children's Oncology Group REACH. And so I'll just say as an introduction that it's a fairly large group. There are more than 220 institutions that participate in Children's Oncology Group trials. And about 80%, a little over 80% of children diagnosed with cancer, not just neuroblastoma, but any type of cancer in North America are treated at institutions that are part of the COG. Unlike SIOPEN and other neuroblastoma-specific cooperative groups, the COG is not just a neuroblastoma organization. So there are committees that address issues related to leukemia, renal tumors, bone tumors, etc. So altogether, there are about 12,000 patients per year across cancers that enroll on COG trials. Just to set the stage for the specific trials that we'll be talking about, I wanted to just review the backbone of COG frontline therapy for children with high-risk neuroblastoma. And I'll just be clear from the get-go that I'll be talking about high-risk neuroblastoma today. We also have obviously run trials for children with non-high-risk disease, which could be a topic of many hours of discussion all by itself. But for today, I'll just be talking about high-risk neuroblastoma in the frontline setting, and then a bit about the relapse setting. This schema is very similar in some ways to what families in Europe and other parts of the world may be used to, but it differs in a couple of different respects. The first part is induction therapy, and the chemotherapy regimen, the absolute specifics about it are less important than to say that in general, it consists of cycles of multi-agent chemotherapy, so that we're using very much similar agents to what are used around the world. The timing of these cycles is a little bit different from what's done in Europe and other parts of the world, where there's a rapid sequence These cycles are given every 3 weeks, with surgery generally speaking after cycle 4, which is earlier than what is done in other parts of the world. And the idea of induction is to decrease the tumor burden that patients are experiencing and try to get them into the best remission that we possibly can. For patients who have a good response to induction, they move on to consolidation therapy, which is really designed to dig your heels in and solidify the gains that you made during induction. And through a series of clinical trials conducted in the 1990s and early 2000s, it was found that 2 cycles of high-dose chemotherapy with stem cell rescue resulted in the best survival rates that the COG had documented to date. After the 2 back-to-back cycles of high-dose chemo with stem cell rescue, patients receive radiation to where their primary tumor used to be, as well as to sites of persistent metastatic disease that were detected at the disease evaluation performed right here. This is a little bit different, again, than how it's done in Europe, but it is what we have worked out over the last few decades. The next stage is called post-consolidation, and this 6-month addition to standard therapy was added based on the landmark paper by Alice Yu and colleagues showing that the addition of dinutuximab plus cytokines improved event-free survival by about 20%. We picked this very unglamorous name of post-consolidation mainly because it came right after consolidation. In North America, we generally don't call this maintenance for a variety of language-related reasons, but it is equivalent to, I think, what people in Europe call maintenance therapy. So this is the standard backbone. There are a lot of nuances to this, but this is what we'll be building from through this talk. I will note that this backbone has been modified over the last at least 10 years or so, based on the results of the ANBL 1221 trial that many of you are familiar with. That trial took the idea from the original dinutuximab trial here in post-consolidation and said, well, if immunotherapy helps in post-consolidation, might it help also for patients who either don't have a good response to induction or eventually relapse? And so in the ANBL 1221 context, we studied irinotecan and temozolomide with dinutuximab for both patients with relapsed and refractory disease. And much to our surprise, we saw some really impressive responses. So it has become standard practice in North America for patients who don't have a good response to this induction therapy to then go on and get chemoimmunotherapy. And many times those patients can loop back in, get back on this track, and move on to high-dose chemo with stem cell rescue. As many of you know, that is not the treatment plan at every institution in North America, but the majority of COG institutions now use chemoimmunotherapy in this way, and that will become important in a slide or two. So this is the modified backbone, so you can get to consolidation either directly or indirectly. So the question for our currently open high-risk trial is whether early administration of dinutuximab, anti-GD2 antibody, improve outcome compared to this strategy that I just described to you of using chemoimmunotherapy only for patients who didn't have a good response to induction. So what I showed you on the previous slide was this part up here, which is the standard arm, arm A, where some patients don't get chemoimmunotherapy at all if they have a great response. Those who don't have a great response can come get immunotherapy here. But the question on the trial is, could you improve outcomes for everybody on arm B by giving anti-GD2 antibody right from cycle 2? And so that's the question. Some people try to say that it's immunotherapy versus not immunotherapy. And really, technically, the question is early for everybody or later for those who don't have a good response. This study is moving along quite nicely. So it's accruing patients at about the rate that we anticipated that it would. We will complete full enrollment in 2028, which now is getting closer and closer now that we're in 2026. And then we have to wait 3 years for mature outcome data. So from the time the last patient enrolls until we get the data, we have to wait for about 3 years. If antibody given early in induction does improve outcome the way that many of us hope that it will, that will become standard of care. But even if it doesn't, even if we show that giving chemoimmunotherapy only for patients who don't have a good outcome is the winner, we will still learn a lot from this study. So just like our colleagues in the other cooperative groups, we've incorporated a lot of translational biology studies that we hope will help us understand not only more about neuroblastoma in general, but also specifically about how to predict which patients are most likely to respond to GD2-directed therapy. As many of the parents in the audience will know, GD2 therapy is not always easy on kids. It has a lot of side effects. And so we'd like to be smart about not only picking the patients who are most likely to respond, but also avoiding exposing kids who aren't going to respond to a difficult and often painful therapy. In addition to those biology studies, we have a new amendment that's working its way through that has been moved along by our surgical colleagues. So I know that many people think about the main medical oncology questions, but we do work very collaboratively with both our radiation oncologists and our surgeons. And the surgeons are very excited about this idea of making 3D reconstructions from CT scans and MRI scans, such that a surgeon who's addressing a complex operation can think about the 3D appearance and hopefully avoid complications in the course of doing the surgery. So that it will be coming through hopefully soon. In the meantime, we're anxiously awaiting the results of ANBL 1531. As I mentioned on the previous slide, with ANBL 2131, from the time the last patient enrolls on the trial until we have the 3-year event-free survival data, just as it says, that's about 3 years. And so in October of this year, we will have the results of most of the arms of ANBL 1531. Just to walk you through that, the patients enrolled on ANBL 1531 and got a cycle of chemotherapy. Oops. Sorry. And while patients were getting treated, their tumors were tested for the presence of either an activating mutation in ALK or amplification of the ALK gene. And those children went on to receive lorlatinib in combination with our COG standard therapy. That arm is still accruing, and I'll discuss that in a minute. So we won't have the results of that part of the study in October of 2026, but we will have the results of the rest. So patients whose tumors did not take up MIBG were enrolled on arm D, and those patients got standard therapy per the COG paradigm. And patients whose tumors were both MIBG avid and did not have a mutation or amplification of the ALK gene were randomized to either receive standard therapy or standard therapy with a cassette of MIBG treatment about halfway through induction. This process was not done based on the request of parents, wasn't done based on the preference of the physicians. A computer assigned the arms as a standard for randomized trials, and patients either received the assigned therapy with or without MIBG. So we're very excited about getting those results. We don't know, they haven't been released. So you can ask me all you want if MIBG works or doesn't work, and I have no idea. Ask me in October, and then I can tell you. So this creates a little bit of a problem for us because let's say in October, we find out that MIBG does provide an outcome advantage, then everyone will want MIBG, but we still need to finish ANBL 2131. So this idea of leapfrogging the trials and getting results while you're still in the middle of a trial does cause some degree of risk. If we find out that MIBG therapy does not result in a survival advantage for kids newly diagnosed with high-risk neuroblastoma, then we just proceed with ANBL 2131 as is. But there's a lot of rethinking that we will have to do if MIBG is the winner. And this really matters. I mean, you might think, why are you taking this risk? Why don't you just wait and see which therapy wins? But if we did that, then we would be waiting from the closure of ANBL 1531 in 2023 until the fall of 2026 and be doing absolutely nothing to try to advance the care of children with neuroblastoma. So we're proceeding at risk when we design our trials this way, but we feel like we have to do it so that we can keep moving the field forward. As I said, with regard to 2131, we'll learn a lot from ANBL 1531, even if the outcomes are similar. So again, we have a lot of translational biology baked into ANBL 1531. We have a lot of studies of circulating tumor DNA, which are really interesting. We have both detailed single cell and bulk DNA and RNA molecular profiling studies, as well as immune profiling studies. And really importantly for us as leaders in the field and neuroblastoma researchers is this idea that some of these sub-studies will be run by junior people. So young investigators are our future. And what we try to do is pair seasoned, we don't like to say old, we say seasoned investigators to help the young people kind of get used to working with the kind of data that we need and conducting these sub-analyses so that they can go on to run the studies in the future. I mentioned Arm E. That is the arm for patients whose tumors harbor ALK aberrations. Those patients are currently being enrolled on this arm, so they can enroll on ANBL 2131. If their tumor is found to have an ALK aberration, they can transfer over to the lorlatinib arm. And that study will continue throughout the course of ANBL 2131. And we hope to have enough patients to enroll on that arm so that will finish at the time that ANBL 2131 finishes. So stay tuned. We don't really know at this time if lorlatinib improves outcomes for patients with ALK aberrations. We certainly hope that it does. I mentioned ANBL 1221 a few slides ago. This was the trial that led us to start using chemoimmunotherapy more often in the setting of a poor response to induction. But we also use chemoimmunotherapy for patients who unfortunately experience a relapse, either during or after treatment for high-risk disease. And these were the data that really shifted our thinking about how to approach relapsed and refractory neuroblastoma. So this was a trial that I had the pleasure of leading with Rajan Modi, which was probably one of the most exciting professional events of my life. We couldn't believe the responses that we were seeing. And about 40% of patients on this trial had either a complete or a nice partial response, which was much higher than the 15 to 20% we had seen with irinotecan and temozolomide alone. So something about the addition of relatively low-dose chemotherapy probably changed the immune microenvironment that the tumor cells were living in and made the dinutuximab work better. So what we have said, in addition to taking this and moving it up front, as you saw in ANBL 2131, we've also tried to figure out how can we increase that number from 40% to something much higher in the relapse setting. And so many of you know quite a bit about DFMO, otherwise known as eflornithine. This is a polyamine depleter in neuroblastoma cells. It blocks ODC1 and polyamine production within neuroblastoma cells. And those polyamines are what help neuroblastoma cells continue to be neuroblastoma cells and be viable and survive. So based on some laboratory work by Mike Hogarty and a trial in the New Agents for Neuroblastoma Consortium, or NAT, the COG ran a trial called ANBL 1821, which combined irinotecan, temozolomide, and dinutuximab with DFMO for half the patients on the study. So you can see these are the two randomized arms, the chemoimmunotherapy versus the chemoimmunotherapy with the addition of intermittently dosed DFMO. That study was run by Meg Macy out of Colorado, and the results were reported at ANR and ASCO last year. And to our disappointment, there was really no difference in response with or without DFMO. The response rate was strikingly similar to what we had seen on ANBL 1221. So you can see here the complete and partial response rate was between 40 and 50%. Even if you added in minor responses, which can be clinically meaningful, the numbers are a tiny bit higher, but there was no difference between the arms. And for those of you who love a graph more than you love straight numbers, these are the Kaplan-Meier curves with survival versus time, and you can see the curves cross. There's no difference between those curves. So we had run this whole trial based on the best available preclinical knowledge and the potential importance of DFMO in neuroblastoma, but we did not see a response advantage there. So we scratched our heads and thought some more about what other kinds of medications could change the immune microenvironment of neuroblastoma cells and potentially increase response. And we reached back to some older trials in patients with multiple myeloma and an old Nance study, and decided that we wanted to look at what are called cell mods, basically drugs that change the immune system, increasing the activity of natural killer cells and increasing interleukin-2. And this came out of, again, the myeloma literature. Iberdomide is a drug that is used in patients, adults with multiple myeloma, which is a very different disease biologically than neuroblastoma, but the immune environment is very important in myeloma, which is why we took a look at this. For those of you who enjoy a diagram, I'm happy to walk through the way we think that iberdomide looks, but for those of you who want to cut to the chase, the idea is to tweak the immune system in a way that's going to make the chemoimmunotherapy work better. Many of the patients who would go on to a trial for patients with relapse neuroblastoma may have been the same ones who didn't have an optimal response at the end of induction. And so they would have already seen irinotecan, temozolomide, and dinutuximab in that modified COG paradigm that I showed you. So we didn't want to just do the same thing over again. And so what we decided to do was to use a topotecan and cyclophosphamide backbone together with dinutuximab, so that they would be seeing something that they hadn't, a combination that they hadn't precisely seen before. So half the patients will get this modified backbone with dinutuximab, and half of them will get topotecan, cyclophosphamide, dinutuximab, and the new agent, which is the CELMoD iberdomide. That trial has been approved by our sponsor, which is the Cancer Therapy Evaluation Program. And we're in the process of getting additional approvals, finalizing the contract, and doing a few other things to get that open. So it's my hope that by the time the weather warms up here in the United States, the trial will be open and we can enroll children on this trial. Again, I do think even if one arm is not better than the other, there's still a lot to learn, both about the immune microenvironment, but also about this different backbone of chemoimmunotherapy that will be studied in a pretty decently sized clinical trial. As we think about these trials that are open now or opening very shortly, we also need to be planning for the future. And we really need to take into account not only the unacceptable survival rate in children with high-risk neuroblastoma, but also the toxicity that's really life-altering for their survivors. And I think many people who are tuning into this call are very interested in the idea that's been put forward by some of our peer institutions about trying to cure children with high-risk neuroblastoma without high-dose chemo with stem cell rescue. And so the idea is that back in the days when high-dose chemo with stem cell rescue first started being used, there wasn't immunotherapy. And the success of high-dose chemo with stem cell rescue back in the 1990s and early 2000s is important and useful. But since the immunotherapy era has dawned, we don't know if we could have substituted that for the high-dose chemo with stem cell rescue, or maybe both are needed. We just really don't know. So these trials are the summary from the UK, Germany, and COG that supported the use of high-dose chemo with stem cell rescue in patients with high-risk neuroblastoma. But none of these are recent studies, and none of them included a head-to-head comparison with immunotherapy. So all of this leaves parents, many like yourselves, in a really tough spot trying to decide whether a transplant is indicated or not. And this paper, I think, really encapsulated beautifully the questions that parents are struggling with. And I thought this paper was incredibly well written, but also I hear parents every day that I'm in clinic agonizing about this question, even to today. And some of the reason that they agonize is shown in this diagram right here. So we know that our chemotherapy causes hearing loss, but so does the high-dose chemo. That's part of the transplant portion of care. We know that patients have growth failure. We know that there's compromise of fertility. There can be problems with kidneys and liver, lots of different issues as a result of transplant and the other things that we do, but a good deal of it is caused by high-dose chemo with stem cell rescue. And so watching parents agonize over this decision really prompted us to design a trial where we could definitively answer that question. And so what we're planning for the future is indeed that definitive study. So I've diagrammed this again here. This is the induction regimen. Patients with a good response march on. Patients who don't have a good response can get chemoimmunotherapy. But the important part of this trial is that half of the patients would be assigned to get the back-to-back cycles of high-dose chemo with stem cell rescue, and half of the patients would be assigned to get chemoimmunotherapy. They would then go on to get radiation and the other components of care. But this is, whoops, I'm having trouble today. This is the big question. And the only way we could think of to answer that in a time frame that was acceptable was to have the patients randomized, half get one therapy and half get the other. We tried to use some advanced statistics to shorten the period of accrual that would be required. And we made a proposal to our sponsoring agency based on an idea that perhaps chemoimmunotherapy might actually be better than transplant. But that proposal was rejected because the strength of the data to support superiority of chemoimmunotherapy was found to be insufficient. And so we went back to the drawing board and decided that this question is so important that we're going to invest a longer period of time to answer it, but to do so in a way that is statistically very, very sound. And at the end of the study and after the time that the data have to mature, parents like yourselves could look at the data and say, they did the right study. This is the definitive answer. I will say that we spent more hours discussing this and debating this than I can ever recount. And we spent a lot of time in the nitty-gritty with statistical design. But this is the conclusion that we came to. And we agreed to invest 5.5 years of enrollment on this study to really provide the best answer that we can. It may affirm the paradigm of using high-dose chemo with stem cell rescue. It's entirely possible that the outcomes with high-dose chemo with stem cell rescue might be better. But even if they're not better, even if the outcomes with chemoimmunotherapy are the same as transplant, we as providers, and I suspect you as parents, would probably choose the chemoimmunotherapy to avoid some of the toxicity of transplant. So the kind of study that we're running is called a true non-inferiority study. We're not trying to show necessarily that one is better than the other, but that the outcomes are approximately the same, and then you would choose the one with less toxicity. So we may shift the paradigm, we may affirm the paradigm, but there's only one way to find out. And I want to just really thank the study leaders, which are Jenny Foster from Texas Children's and Naveen Pinto from Colorado, along with our very patient and excellent statistician, Arlene Naranjo, and a number of the other investigators you see pictured here. I'd just like to highlight the participation of Kate Mathey, who's one of the grandmothers of neuroblastoma. She's partially retired, but has spent an incredible amount of time giving us her wisdom and input on this trial. And also Fiorella Iglesias, shown here from Memorial Sloan Kettering. That institution has been a big proponent of not doing high-dose chemo with stem cell rescue. So Fio has been very helpful in providing the viewpoint from Sloan Kettering. But I'd also really like to thank our parent advocates who have been up to their eyeballs in this whole debate. That's Jen Bell with her daughter Katie, who's a long-term survivor of high-risk neuroblastoma, and our newer parent advocate Lou Esposito with his son Nicholas, because they've questioned us at every step of the development of this trial and really tried to always bring us back to, well, how are parents going to think about this? Is this the right thing for the patients and the parents? And it doesn't matter so much what you think about with your fancy statistics, but how are parents going to interpret this? Are parents going to be willing to enroll? And so we just really appreciate the advocate voice as we've been developing this. So that concept has been written. It is going to undergo review at the end of this month, beginning of next. And then it has to go through a whole many levels of review. So that trial will be open, we hope, right at the time that ANBL 2131 finishes. And it reflects our willingness to make an investment in time and resources to answer the questions that really plague parents, I think, a great deal, and they spend a lot of time agonizing about. We want to generate data that are truly helpful to the people who are sitting there making the decisions. And also, I think it fits in with our idea that, you know, we're taking an obstacle, which is the period of enrollment of this trial, to get the best data, but turn it into an opportunity and try and learn as much as we can from the data, from the existing studies, and the data that we're going to collect with this randomized trial. I think also we have had to really lean on our parent advocates and advocates from outside of the COG. And I think by doing so, we've forged some new partnerships that I think can help us a lot as we go forward. I think also the lab partnerships, we've been talking with a variety of laboratory investigators about how to use tumor samples, blood samples from our existing trials and our future trials to try to learn as much as we can. I also think through the course of discussing our current and planned trials, international collaboration and input about what the effects of our COG trials will be on children and families in other parts of the world has been really helpful. And I think we have an excellent collaboration with our ScioPen partners, and we're beginning to talk more and more with cooperative group leaders from other parts of the world as well. So I'll wind up here. I think you all know about the pledge that Einat and her team have put forward, and I'd be very interested to hear your questions. Should I read the questions in the Q&A? Is that right? Okay. All right, here we go. Okay. If a child has an ALK mutation, what is the best course of action in the relapse setting? What do we know about lorlatinib for those kids? Okay. So the NANT 1502 trial was a study of lorlatinib for patients with relapsed neuroblastoma with ALK aberrant disease. And there was both a single agent arm and a combination arm. And the results were encouraging. So it didn't cure everybody, obviously, but compared to the historical outcomes for children with relapsed neuroblastoma and ALK aberrations, the results of the NANT 1502 were quite useful. we've been able to, in the US, get insurance authorization for lorlatinib in this context. I'm not sure what happens in other parts of the world, but I do think when we appeal to the insurance providers with the actual data from the NANT 1502, we have been able to be fairly convincing. Is that the only way to approach ALK aberrant relapse disease? No, there are other ALK inhibitors that have been studied or are about to be studied in other trials. So I do think that field is evolving. But the one that's most accessible and seems most promising right now is lorlatinib. We do need to think about other kinds of ALK-directed approaches and also approaches that take into account the accumulation of other mutations in tumors. So if you continuously target ALK, tumor cells are smart and they're going to generate resistance mutations that make lorlatinib less effective, and new mutations are going to develop in other pathways as well. So I think it's hard to expect that lorlatinib or other ALK inhibitors are going to be the final thing, but there are other trials out there for patients with ALK aberrant disease. So there is an ALK CAR T cell trial that's really interesting. There will be ALK degraders coming out. Antibody drug conjugates will certainly be of interest. So I think there's a whole world of ALK-directed therapy that's opening up. Are there any trials looking at neuroblastoma stem cells and how to eliminate them? I don't see trials for relapse, especially multiple relapse. That's a really good question, Christina. So in North America, we've sort of made a decision that there's so much work to do and there are lots of people to do it, but that we're going to take the funding that we have and apply it where we can do it best. So I've mentioned NANT several times. NANT is a new agents consortium primarily focused on phase 1 trials. And that's what they do. Those institutions are set up to do phase 1 trials very well. What the strength of the Children's Oncology Group is a little bit different. So it's over 200 institutions, some big, some small. Some of the institutions are really set up to do phase 1 trials. Like my institution is large. We have a very active early phase trials program. But some of the institutions are small and they can't do the early phase trials because they just don't have the patient population and the staff to support it. But they do have patients with relapse disease. And we have found that for patients and families, they really prefer to stay at their home center at the time of first relapse. They may be anxious to travel and go to new places at the time of subsequent relapse, but providing trials for first relapse is really what has become in the purview of the Children's Oncology Group. So that's why I didn't really talk so much about other trials for relapse, because the COG is focused on frontline and first relapse. Okay. I read about a trial for relapse kids. Kids received MIBG and then did stem cell rescue with their parents' stem cells and then showed some response to GD2. In the COG, we have not conducted a trial with parents' stem cells as the rescue. The ANBL 1531 trial used autologous stem cell rescue, so the child's own stem cells. The idea behind autologous stem cell rescue is just to improve count recovery so people can move on to their next therapy sooner. And that's the more common use. I think what you're getting at is more of a haplo type of high-dose chemo or MIBG therapy with a more of a transplant, trying to make use of the immune system a little bit more than just speed up the recovery. It's very interesting, and I know that Tim Flott's group has been very excited about this, and we're really anxious to see further results from their clinical trials. Okay, for a patient who has gone through frontline therapy, ANBL 2131 Arm A, no ALK, no, gotten a good, albeit partial response. What does the data show for de-easing? Okay, this is good. Jordan, thank you for that question. This is so tricky. And I've spent a lot of time trying to think about and understand the DFMO data. As many of you know, DFMO was approved by the FDA for treatment in the continuation phase. So patients who got all the way through therapy, completed their post-consolidation, and have responded. Those patients can get up to 2 years of DFMO. The dose of DFMO in that setting is much, much lower than the dose in the 1821 setting, and it's very, very well tolerated. When the initial trial was done, it was a single-arm trial. There was no contemporaneous control. And so it was really hard to understand the meaning of those data in a single-arm setting because there's so many variables there, and you don't have half got it, half didn't in a single-arm trial. So I commend the investigators who ran that trial because they went back and looked at a large cohort of COG patients who did not get DFMO, and they did the very best they could to try to match characteristics of those patients, age, sex, like 14 different characteristics that they matched on, and they did as good a job as anybody could do. But I think for many of us who follow kids with neuroblastoma, you can't make two kids exactly the same just based on their demographic characteristics and their MIC-N status. There are lots of variables about each kid's individual situation that are going to be a little bit different. And so I think I and many others have just found the data really hard to interpret. And I guess for me, it made me think even more strongly that we really need to do randomized controlled trials so that we don't leave ourselves and parents in the situation of trying to figure out on the back end, like, what did these data really mean? If you do a trial where half the kids get something and half the kids don't right up front, in the end, it's probably not going to take you much longer to enroll that study than to go back and do all these statistical machinations to try to make sense of the data. So that was a long-winded answer, Jordan, to your very good question about DFMO. And honestly, what I do when I sit down with patients as they're reaching the end of post-consolidation is have a whole series of conversations about the DFMO data. Even if patients don't want to hear it, I go through it, and if they don't listen to me the first time, I bring them back a couple weeks later and talk about it again. And if they don't want to talk about it in that level of detail, I say, okay, and then I bring them back a couple weeks later, and they get really tired of me talking about this. But I think it has to be joint decision-making about how much do parents understand the data. How much do they want to keep going with therapy? How much do they want to be done? There are parents who very much just want to, they've spent a year and a half getting therapy and they want to be finished. And they don't want to be a neuroblastoma patient anymore. They don't want to have to come to clinic. Other parents feel very strongly, if there's even the faintest chance that this could help my kid, I want to do it. And so I'm not dogmatic about that decision. I am exhausting about that decision. The patients will tell you that come see me that it's exhausting talking to me about this, but that's how I do it. There are some people who feel very, very strongly that DFMO is fantastic and everybody should get it. There are some people who feel very strongly that the data don't support it. And I have to tell you, I'm in that annoying middle. And we have some joint decision-making around that. Are you studying the origins of relapse? Is it microscopic disease that was never eliminated despite several rounds of consolidation, months and years of admission? Or their new focus of disease that were dormant and just activate for some reason? That is an amazing question. And I think there's probably a little bit of both to that. I do think that we can only see what we can see. And so when we do a scan, when you see a mass on a scan, you know, it's thousands and thousands of cells. We can see a little bit better, you know, in the marrow, we're looking at clumps of cells, but nonetheless, there's probably disease that remains that our eyes can't see. And we think that in many people, that low-level disease is managed by immune surveillance, that our immune systems recognize a cell that shouldn't be there and put the kibosh on it. But in a disease where there may be immune dysregulation, maybe that's part of the problem, that the immune system is not able to pick out those few remaining cells. But could there be new disease cropping up? In patients who have a predisposition for neuroblastoma, we fear that that is probably the case. Most patients don't have an identified predisposition. But I think we need to learn a lot more about the biology of disease recurrence. So Christina, your questions are the right ones, and I just don't think we have all the answers. Okay, Jordan says we're out of children's. Dr. Pinto, he's very thoughtful about this. Yes, so you'll have a long, involved conversation with Dr. Pinto. Some people draw the conclusion that based on the 1821 study, if DFMO didn't work in higher doses, could we expect it to work in lower doses? That's a logical way to think about it, but the disease context is also really important. So not only are we looking at a different dose, we're also looking at a different disease status. So in the ANBL 1821 context, you're asking DFMO to do kind of a lot. A lot of those patients will have bulk disease. Whereas in the situation where you've completed all your therapy and you're in a good response, it's a little bit easier ask. And so the clinical context is just really different. But I'll be very interested to hear how your conversations go and whether they're as exhausting as mine. I hope I got through the questions that people had. Yeah, any others?
I don't see any more questions, but thank you so much for your time, for your clarity and your leadership, your work at COG and at CHOP, and your ability to explain such a complex research in a thoughtful and accessible way. It helps families to better understand the path forward and the progress being made. And to everyone join us today, thank you for your questions, your engagement, and your commitment to learning what makes this community strong. Together, we can definitely building an understanding, connection, and hope. And as we look ahead, our next webinar session will take place on April 6th when we hear from Dr. Kushner, who will share updates on MSK clinical trials and their approach to neuroblastoma. Before then, we'll be taking a short break to allow Solving Kids Cancer to host their upcoming online conference, and we warmly encourage you to join their session as well. Until next time, take care, stay informed, and remember, together we can change the fate of children with neuroblastoma. Thank you so much.